want to apologize for the typos that I'm just now noticing. But anyway, I'm Dr. DeMars. I am an internist, a hospitalist at the VA, and we are very fortunate to have Dr. Starkeybaum here as our rheumatology expert. Dr. Starkeybaum, I'll let you say a couple words about yourself if you want before we get started.
Oh, sure. I told earlier I interned in 1970. I spent the whole year at Harborview, and I've been learning ever since. Good to see you guys.
Excellent. All right, well, we will jump in. You guys all should have gone through these. Question 1 about fibromyalgia and treatment for it. Can all of you put your answers into the poll and we can kind of see where we ended up as a group? Oh, I guess I have to answer too. Excellent. So E followed by A.
Yeah, well, good. That's a good answer. We don't use narcotics for fibro. Pregabalin is a reasonably scalable and effective medicine, and that's the right answer. And apparently, duloxetine is contraindicated, or at least somewhat, with the presence of the other antidepressant. So pregabalin's the right answer.
Yeah, so we have here, oh, why can't I switch? Hold on, I can't move. Uh-oh. Sorry. Can I go to the next one? Sorry, folks. Here we go. So you guys will get copies of all of this. We're not going to go through all of the small text. That's what MKSAP included as the answer. But yeah, we highlighted the fact that, yep, it would just be concerning for like a serotonin syndrome risk. But otherwise, there's no reason why duloxetine would be the wrong answer in a patient who wasn't on another antidepressant or something that would interact. Anybody have questions about that question? Okay. Question 2, 50-year-old man, some knee swelling, a long history of psoriasis and psoriatic arthritis. They talk about his physical exam. And then we've got the arthrocentesis results of the fluid. So let's vote here. What do we think is going on with this patient? A and B. Does somebody who voted for B want to tell us why? You guys can just speak up, unmute yourself. Just let us know what you talked about in your group.
I guess I would say in defense of B is, you can certainly get an infection in a joint that's affected with psoriatic or any other form of arthritis. One of the things against it is the white count in the joint of only 40,000. Generally, we think of higher, but that's not a firm number. And so you need to tap that joint because of this conundrum. Which flavor is it? And if you see crystals, you're home free. If you don't, you may not. You can culture it. And one of the truisms is you can always have fleas and lice. Don't forget.
Yeah, so I was kind of surprised that nobody said D, but I guess what give it away maybe is because it was one joint instead of multiple. So that's kind of what they were highlighting there. One joint, infectious hemarthrosis, or a crystalline disease. So yeah, gout is the answer. Anything else you want to say about gout and psoriatic arthritis or psoriasis, Dr. Starkeybaum?
No, I think in other words, it's a fairly common arthritis. You could have in both rheumatoid and psoriatic arthritis, you could have a flare and push the white count in the joint up to 40,000. But when you have that kind of a particular joint, the knee is easy to aspirate. It should be aspirated. That's where the answer is.
I was not aware that the risk of gout is so much higher in patients with psoriasis. So that was a good teaching point for myself.
Yeah, it travels in the same company, you know, metabolic syndrome, obesity, that sort of thing.
Mm. Okay, question 3. Patient with lupus, treated for lupus or nephritis. So medications, and then what do we do for further workup for health maintenance? Does
All
anybody
right.
want to talk about their answers?
Yeah, that's good because this is something that's emerged over the past decade or so. And I remember hearing about a young woman in the emergency room with chest pain and lupus history, and was dismissed with presumed pericarditis from lupus, but in fact she was suffering a myocardial infarction. So nowadays, this is a real problem, and we pay attention to the risk factors for cardiovascular disease. For example, a lupus patient who smokes is a train wreck heading, and so you would go over those things and really pay attention to the cardiovascular risk things, even in patients with stable lupus.
So just to
Question
clarify
4.
that,
Oh, yeah.
that means talking about tobacco, talking about lipids, talking about blood pressure, searching for diabetes, those kinds of things.
Yep, exactly. Yeah, just in other words, as a rheumatologist, we might say, go see your internist and all this, but if you're the internist or whatever, you have to pay attention to it because it's a real problem. The inflammation in these diseases appears to increase the risk of cardiovascular disease with all the other usual factors that go into it. So that's the background of it. One of the reasons we use hydroxychloroquine in almost all people with lupus is that it tends to prevent this to a degree as well. It's a good drug for prevention of that.
Excellent. A 56-year-old with gout, tapering her prednisone, following an acute flare, rash on allopurinol. What are we going to do?
Okay, well, that's good. That's the right answer. And the good news is we have an alternative to allopurinol. This lady had a rash, and so there's no reason to try that again. We used to have to desensitize people who had a history of a rash, but nowadays you have a good alternative, and so that's the right answer. One of the things you should realize is that in starting allopurinol, we always worry about really severe reactions, and you can anticipate that in patients by doing an HLA test. I don't know if any of you know the HLA test I'm talking about. So it's B5801. You can order this in the clinic, and people of Asian ancestry, maybe blacks, but lots of people have that as a higher risk in the population, and so we would recommend, it's not on this test, that we would recommend just for extra credit, that anybody you're going to start or consider starting allopurinol, you do that test first, because their risk of a severe reaction goes up 80-fold. And so it's the real deal.
Wow. So is that your practice then? You tested everybody that you think
Yeah.
has a higher risk?
Yeah. If they've already had some allopurinol and not had a problem, I tend not to. But yeah, going forward, it turns around in about a week, and there's no hurry in starting these drugs.
Excellent. All right. Question 5. See. Gout, then into prednisone. Okay, so gout, CKD,
I love these questions.
Tacro.
They're good bread and butter gout crystal questions. This is good. All right. Yeah, this is good. So we call this vitamin A, because Anakinra, which is harder to get as an outpatient, but at the VA you can in fact get it, is just an amazingly effective drug, 100 milligrams every day or every other day, depending on the renal dose. And it just, the patients will jump up and hug you when you come on rounds the next day.
Excellent. And are there contraindications, people we cannot give it to?
Not that I know of. In other words, we use it immunosuppressed. It avoids all the high dose steroids. It acts very quickly, and it will work for both crystals, uric acid and CPPD crystals. And so, yeah, it's the cat's meow.
Excellent. And I'm assuming that more people probably didn't pick colchicine because of the CKD, but I didn't know this about its interaction with tacrolimus and cyclosporin. So that's important to know.
Yeah. I mean, colchicine, we used to give it IV. It used to be available, and it was given so frequently to people with kidney disease and the catastrophe of bone marrow suppression, and then also neuropathy. And so both of those neuromyopathy. So it's a bad disease, bad drug in CKD.
Anakinra doesn't have but any side effects we should be aware of or worry about?
Not really. Usually it's only given short term, and when they need it longer term, then you may worry. And leukopenia has been found once in a rare time, but it's actually a very safe drug, and I know of no contraindications. Canakinumab is a long-acting IL-1 blocker, but it's very expensive, and you're going to have to get the hospital high cost committee to approve it before you use it. So Anakinra is much easier to give and to get.
Okay. Sudden vision loss in a 35-year-old, abdominal pain, fevers, myalgias, hypertensive, but unequal on each side, blood pressure wise, elevated ESR. What is going on with this woman, and what are we going to do?
So I would say off the bat, this is somebody you call rheumatology for, because you know, this is an uncommon problem, and this is the correct answer. And the reason is partly because it's not giant cell arteritis. She's too young. There's trouble with the arm. It's not polyarteritis nodosa because there's no nodules on the skin. And so Takayasu's is, something to be thinking of in a youngish woman like this. It's relatively rare. The gout questions are absolutely common. These questions are not common. But here's kind of a nice review of medium-sized vessel vasculitis. So if you read the answers to this question, you'll have a decent kind of overview of vasculitis in general. So I really recommend you come back and study the answers in a little more detail, because they delve into some facts.
So yeah, this one, I guess, right, more prevalent. Are the other ones seen more frequently or less frequently in different ethnic backgrounds?
Well, this is supposedly East Asia females, but we see it in all races and so on. And Takayasu's is more common than polyarteritis nodosa. Giant cell arteritis, of course, is very common, but that's a whole different drill. It's an elderly person, headache, maybe blindness, jaw claudication, accompanied with polymyalgia rheumatica. So in none of these tests is there a blood test that does it. You're talking clinical and imaging, and usually MR, angiogram, that sort of thing. We would routinely do an ANCA because it can occur and it's quite common, but this doesn't have any of the manifestation, no pulmonary renal disease here.
And it's not, especially at the VA, it can be challenging to get MRIs. Would a CTA not give you enough information to diagnose this?
It might. I think they're used kind of interchangeably, and so it depends on the ability of the radiologist to read that.
Okay. And anybody out there that has any questions or comments? Oh, is there something in the chat? Oh, this is from before. What is the typical screening that you do in clinical practice? Oh, I think you already asked that though, right? Cardiovascular disease with lupus.
Yeah.
Was this answered?
I think we already, yeah, I sent a message.
Okay.
I think we already
Okay,
that,
perfect. But yeah, feel free to jump in and interrupt guys and ask questions.
Oh, I love this one. This is a great one.
58-year-old, pain in a wrist for 4 days, has had similar things in the past, swelling, warmth, and redness, normal labs, and then this radiograph. What are we thinking? This is where they like to get you, right? They're not going to ask you what is the disease. Instead,
Right,
they're going to ask you to think beyond
this
that.
is more or less a typical board question, and let's see what happens here. Okay, well, this is a decent spread. So the clue, the key to this is if you look at the MCP X-ray, you can see that the second ray, the second MCP from the right, is narrowed. There's an osteophyte. There's also some flecks of calcium, some little erosions, and that is an unusual joint to have osteoarthritis in. And so one of the pearls is when you see that.
You're referring to right here?
Yeah.
Can you see my, yep. Okay.
Right, thank you. You think of hemochromatosis because especially in men where hemochromatosis is not so rare, this may be the presenting manifestation. They may not have liver or other disease. And together with the chondrocalcinosis, you can point with your pointer on the wrist there, the little flecks of calcium in the radiocarpal joint there, down below here.
Oh, down here.
Over the ulna, just off of the ulna, right there. Yeah, all of those little guys. That's chondrocalcinosis. And so this screams, well, this is CPPD pseudogout type arthritis, but together this then would would bring up the possibility of hemochromatosis, and the screen for that is a high ferritin. You have a ferritin of 1,000, the SAP may be 80 or 90%. I used to see one of these patients a year at the VA because, you know, hemochromatosis is not so rare. The gene for hemochromatosis is 7% in the Caucasian population. So I'll just throw out a question to it. Does anybody know if the ferritin is 1,000, how you can confirm the diagnosis of hemochromatosis with a blood test? Okay, well, the answer, oh, here it is, DNA test, perfect, absolutely. It's the hemochromatosis gene. And so it can be ordered, and what you get back is whether it's present in heterozygous or homozygous amounts. C282Y, yeah, exactly. Ooh, that's beautiful. That's the HFE gene, and that will confirm the diagnosis if it's homozygous. And you don't have to do a liver biopsy. You don't even have to send them to, you know, hepatology or anybody else. But you do, if they have that and their iron is high, then you got to start treating that with blood phlebotomies periodically. That's the treatment. So this is a good internal medicine case.
Right. So yeah, also I guess, right, hyperparathyroidism, hypophosphatemia, hypomagnesemia also causes.
That would cause not so much the hooked osteophytes as the chondrocalcinosis, but that hooked osteophytes, that's pretty specific. I mean, it's not absolutely specific, but in a 50-year-old person who's not a laborer, that's an unusual form of arthritis.
Very good. All right, question 8, progressive dyspnea. Can't read the whole question because of where, there we go. Sinusitis, dry cough, paresthesias, some abnormal labs, opacities in the lungs.
So this is clearly an ANCA vasculitis. You know, they're high sed rate, pulmonary renal syndrome, positive ANCA. Question is, how do you treat that in somebody who's, you know, got a rising creatinine? It's interesting that we've got another, so rituximab is absolutely the right answer here. Now, mycophenolate, I suppose, could come up, and we've got a question later on with a lupus patient who's got rising creatinine, and in fact, in that situation, mycophenolate is acceptable, but in ANCA vasculitis, the choices are Rituxan or cyclophosphamide, and we tend to use Rituxan in preference these days to cyclophosphamide. So yeah, this is a nice little review of, you know, ANCA vasculitis. This is the most common vasculitis that we see, you know, serious patient outcomes in the hospital.
And so do you agree with the statement? It says that glucocorticoids plus methotrexate for active non-severe GPA.
Right. Yeah,
Okay.
yeah. I mean, in other words, methotrexate cannot be given if the kidney is badly affected because it is excreted almost exclusively by the kidney. So if your creatinine is rising and you don't know where it is, you can't use methotrexate. But for life-threatening disease, Rituxan and steroids are really fine. And
Mhm.
somewhere in there, they talk about plasma pheresis, I think. Yeah, plasma exchange, they say up here in the middle of this paragraph. That has actually been studied, and most people now say there is no benefit from plasma exchange. And you may once in a while see, you know, somebody who's desperately ill, and it's a big deal to do plasma exchange in these patients, and it's hard work, and it appears not to be really indicated.
Sure. What other like rheumatologic diseases do you do plasma exchange for?
You know, very few these days. I mean, anti-GBM disease, perhaps, and certainly thrombotic thrombocytopenic purpura. And there it's not plasma pheresis, but plasma exchange, because the problem in TTP is you have an inhibitor for the enzyme, the von Willebrand enzyme, that's preventing the thrombotic strands of fibrin from forming. And so you want to get rid of the bad actors and supply the good actor, which is the enzyme in normal plasma.
Got it. Thanks. Question 9, rheumatoid arthritis. Let's see. Some new erosions. How do we manage him? Has been on methotrexate and sulfasalazine.
Okay, so we have a word salad of all of these nice medicines, and you know, how can you go wrong with any of them? And so the answer is we sort of tend to start with the TNF inhibitors, which is adalimumab, that one there. And given his, yeah, and so this was not a surprise. The other choice is tofacitinib. We worry these days, it's an oral pill that's pretty effective, but it has risks with thrombosis and maybe even coronary thromboses, and he has coronary artery disease, so you wouldn't use that. You might use adabapt. It works pretty good. Anakinra doesn't turn out to work very well for rheumatoid arthritis, and tocilizumab is just not a first-line drug. So adalimumab or etanercept or Enbrel is the other one. And the point is, when RA continues to go without, progresses in spite of methotrexate, you add another drug, and we treat to target, because we now have so many drugs to treat rheumatoid arthritis that progressive disease is hard to accept.
Sure. All right. And I guess about Abbott, how do you say it?
Abatacept.
Yep. They talk about
Against, yeah.
COPD exacerbations. Do you see that clinically? Do you avoid it in patients with COPD unless they're like really bad COPD patients?
I didn't know that, so I learned something here. Yeah,
So maybe not so much in clinical practice.
yeah.
Okay. All
All right,
right.
this is a good test too. This is a good question.
So a hand rash, weight loss, rash on the face, some weakness.
So that hand picture, especially in somebody with weakness, is the Gottron sign. And what I learned from the question here is that, or the answer is that it's both the rash of Gottron and the papules. And if you look closely at the little papules over the DIP joints, or the PIP joints, rather, the proximal interphalangeal joints, there's little bumps on these fingers along with the rash, and that's both Gottron's papule and Gottron's sign. So that, along with the weakness, is dermatomyositis. End of story. And the other thing it emphasizes here, you actually do not need a biopsy to make these diagnoses these days. So what you need to do then is the clinical syndrome And there's now a myositis antibody panel, and we get that, and that's very helpful, and they don't go into it in this question. And so a middle-aged or, you know, a 65-year-old person with new onset dermatomyositis has a risk of cancer. And so the right answer is the colonoscopy one. And so I can see we need some teaching on that. And so this is a good, the answer here is well described. There are myositis associated antibodies that predict higher risk of cancer, but dermatomyositis by itself is associated with higher risk of malignancy. It says 3 to 12-fold.
Yeah. So screening, and I thought this was interesting. It looks like because it's such a high risk, even if screening is negative and you're worried, people are just going to kind of pan scan and really look.
Exactly. Yeah, right.
Okay. All right.
Oh, I like this one too. This is a good question.
Progressive weakness. Oh, shoot. Sorry, guys. I didn't mean to do that. Oh, well.
Well, yeah, but the key here is 3 years of weakness. The fact that he's on atorvastatin raises your radar that this could be statin-induced myopathy. But on exam, he's got atrophy of the forearm muscles and a weak grip. These patients can't button their shirts, and his CK is only 300, so it's minimally elevated. So this very slow progression, very low CK, and distal involvement all screams inclusion body myositis. And so this is, again, you can get a biopsy, but the clinical syndrome is pretty definitive. Statin myopathy is the real deal. It's rare. It usually causes very high CKs and much more rapid progression.
And then with the statins, it can come on at any time during treatment,
Yep,
right?
Yeah, it doesn't have to be right away, and it can certainly happen after a period of years. The term polymyositis, number B, is something that we're being taught now is the last thing you think of. There's so many subtypes, inflammatory, immune-mediated inflammatory, the statin inclusion body. So there's so many other types. And so this is where the myositis antibody panel is very helpful. And that should be ordered in basically everybody with presumed myositis. So show us the answers to what happened.
Yeah, I mean, I think we gave it away, so we didn't
I
even
know,
do
but
it.
what was the vote? Did you see the vote? I didn't.
Well, I don't think we didn't even vote,
Oh, okay.
right? I think, yeah, right?
Oh, yeah, I didn't even put up the poll.
Yeah, sorry, I ruined
No,
that
it's-
one.
All right.
But yeah, I mean, this was news to me about the distal muscles versus the other myositis.
Right. Yep.
Was
How
helpful.
do you button your shirt? Well, I can't.
Yeah.
All right. Well, this is a cool question. It's a little bit esoteric, and we'll see how you vote. So the key to this is in the photograph of his finger. And if you look carefully, it's not his joint that's swollen, it's the whole finger. And so you might be thinking, well, this is RA, rheumatoid arthritis, but in fact, this is going to be a spondyloarthritis because this is a dactylitis. And yeah, okay, well, good. We got it. 68% got it. So the rheumatoid could have been suspect, but when you go back and look at this picture, you'll see that it's the digit that's swollen and not the joint itself. So in this case, you can clinically obtain an HLA-B27, and that's a useful blood test to obtain in one of these suspected diagnoses. And you can, if you're suspecting rheumatoid arthritis, the two serologies are both rheumatoid factor and anti-citrullonated peptide antibodies, CCP. So we almost always order both of those together.
And the HLA-B27, if that was negative, I mean, what's the sensitivity and specificity?
Well, for reactive arthritis, it's not as high as for ankylosing spondylitis with sacroiliitis. So that if it's positive, you're kind of home free. If it's negative, but your rheumatoid and CCP antibodies are negative, you might have the eye doctor see them. It's a little harder diagnosis when the B27 is negative.
But it's possible. It doesn't totally rule it out.
Yep.
Okay.
I think this is sort of a nitpicky question, but let's see what you did on it. In other words, she's got PMR and she's had a flare, gotten worse. What do you do? What I learned from the question was interesting from the answer. So let's see what you chose. So polymyalgia rheumatica is a pretty common disorder, and prednisone is still the mainstay of treatment, and they usually respond very quickly to prednisone right away. All right, so it's all over the map, and I can hear you. What I learned from the answer is that the Society American College of Rheumatology is that you go back up to the last dose that actually worked and use that first. So 60 milligrams in this person would be overkill because there's no vision loss, and so you don't need 60, but 30 would certainly get improvement right away, and adding some prednisone and methotrexate I think is also acceptable. We use it. The data showing methotrexate works is not the best, but sometimes it helps, and methotrexate is a good anti-inflammatory. So you're all right, and I don't think there's I would say C is the one that I would put down as the least appropriate. Anybody have questions on that? And they didn't have the IL-6 inhibitor, saralimumab, or tocilizumab is also being used, I think, in this case.
I thought it was interesting, in other disease processes where they talk about how, you need to start some other drug in order to get them off the steroids. This one,
Right.
You just start to wean at later.
No, you make
By
a
itself.
good point, and we tolerate long-term year of prednisone in the dosage. We try to be down to 5 and 1, taper very slow, and I almost always add methotrexate when I'm in a situation, but and it's going to be hard to get saralimumab or tocilizumab, Actemra. They're expensive, and so is this seronegative rheumatoid arthritis comes up, and how would you might treat that with methotrexate and some of our other medicines. We almost never use a TNF inhibitor in polymyalgia rheumatica, but methotrexate I think has a place.
Yeah, and I guess their only reason why D is wrong is just because they've only had one flare, but they're definitely saying if they become more problematic, then that would be the answer.
But methotrexate is a very well tolerated drug. It's safe. We've been using it for 30 years to treat rheumatoid arthritis, and the complications from it are nil. And it's an anti-inflammatory agent. And so I don't quite share you know, relegating it to
Mhm.
the lower option D here as they've done.
Gotcha. Okay.
All right, this is a good question. And we talked about this earlier. He's got lupus. And, you know, he's got all the manifestations of lupus, positive serologies, double-stranded DNA, rising creatinine, low complements, blood in the urine. He's got lupus nephritis. And it does tell you down in the corner, prednisone is already initiated and a kidney biopsy has been done. So the question is, what do we use to treat sort of acute lupus nephritis? And I'll be interested to see what you come up with here. Okay, well, you know, that's pretty good, but hydroxychloroquine we use in everybody, but mycophenolate is the key here. And it used to be the choice was mycophenolate or perhaps cyclophosphamide. And we have found that cyclophosphamide actually works pretty good in lupus nephritis. You use it pulse, you give it for 6 doses every 2 weeks, 500 milligrams. That's called Euro-Lupus protocol. And patients do quite well. So that would have been another good choice here. But it's the mycophenolate, not the hydroxychloroquine, that has the real muscle in treating lupus nephritis. And steroids are indicated right away.
Yeah, I think it said, I thought I read somewhere like, yeah, you're not going to delay to wait for your biopsy, right? Where we want to like wait sometimes for
Exactly.
steroids when we biopsy things.
Yeah, I mean, in other words, all the hoofbeats line up here. He's got you know, high double-stranded DNA, high titer ANA, low complements, active urine, rising creatinine. Something's happening, and he almost certainly would have some evidence of active lupus nephritis, and so that's when you plunge ahead and treat aggressively. And cyclophosphamide is still used here.
And I thought it was interesting to see in option D, they talk about how the anti-double-stranded DNA as well as the complement consumption is a risk factor for kidney disease. If you have a patient with lupus and they have those markers, but their kidneys thus far are doing okay, are you monitoring them more closely for the
Like a
development?
hawk, absolutely. And you might even do a biopsy, and there's literature that suggests or that shows some of these patients, in spite of having nothing in the urine, still have nephritis and are at risk. And every nephron has you know, you don't want to lose nephrons because it's a one-way street. And so any patient so we follow complements and double-stranded DNA routinely in our clinic because they're useful markers for lupus nephritis. They don't always tell you everything else about lupus, but lupus nephritis, they are very helpful.
How often do you check them?
Oh, it depends a little on how sick they are, but regularly, it's every 2 to 3 months if they're coming into clinic. Lupus is a complex disease. It starts out, you know, people get quite sick, they get it under control, just like Our Lady in the first question. You know, she's been stable for years, and now we're worried about her cardiovascular. But patients should basically be on hydroxychloroquine lifelong, because it's a useful drug in sort of keeping the disease stable. And if they have nephritis, they should be looked at very carefully and continued on probably mycophenolate or azathioprine sometimes, because you don't want them to have a flare. You'd like it to control it. And it's, you know, they become good friends with rheumatologists or nephrologists because this is a chronic disease.
Oh, shoot. Hold on. I did it again. Where am I going? Hold on. Oh, okay. All right.
All
here
right,
we are.
this is a good one. He's got a rash and he's got abdominal pain and he's got nodules on his extremities. And so, and he doesn't have really much pulmonary renal disease. He does have an abnormal creatinine, but yeah, the angiogram is going to be the absolute helpful test here. So this is going to be polyarteritis nodosa because of the abdominal pain, the neurologic syndrome. The ANCA panel, I would certainly order it, but it's not going to establish the diagnosis. That's the problem. Is if it's positive, you're going to wonder still because he doesn't have a standard pulmonary renal syndrome or ANCA vasculitis picture. You wouldn't biopsy the nodules to get you the answer. A kidney biopsy wouldn't really help you. It might not even show nephritis because his urine looks pretty good. So the angiogram, magnetic resonance angiogram, is how you would make that diagnosis. This is a rare disease. We puzzle over these, and when the angiogram is positive, then it's helpful. And these will be treated aggressively, maybe with IV Cytoxan, maybe with Rituxan, maybe with mycophenolate. We don't have a standard proven therapy.
So yeah, our symptoms are basically due to, the vessels
Yeah.
leading to the kidneys, as well as mononeuritis multiplex,
Yeah. So
and then the skin lesions.
I commend to you the answers for these various vasculitic questions because these are good reviews of sort of the overview of how you approach diagnosis of vasculitis. And we talked about Takayasu's. Here's polyarteritis nodosa, giant cell arteritis that hasn't really been talked about so much here. But these two vasculitides are tough diagnosis to make.
Yeah, so it seems like in the small vessel vasculitides, you're typically biopsying, right? And you're doing imaging for the larger vessels, seems to be the
If you
trend.
have purpura of the skin and not much else, the biopsy may be helpful, but I won't tell you who it is. So it's a combination of a clinical with the serologies, and most of our tests will be a rheumatology gropogram, which is an ANA, an ANCA, maybe rheumatoid factor complement levels. That will get you started. If you have evidence of kidney disease or pulmonary renal disease and your ANCA is positive, nowadays we're done. We don't get a biopsy to confirm just which flavor it is because that's so characteristic. In the polyarteritis Takayasu's world, the large vessel vasculitis, there are no blood tests that help you. So it's a clinical plus the imaging, and there's no biopsy. So we're doing a real fast run through all the vasculitis here, but I think these are important things, and these little answers help you kind of keep that in mind. So now we're moving into the final phase, and we got some scleroderma questions. The key here is the positive centromere antibody. So let's see what the answer shows here. But nowadays you think of scleroderma, systemic sclerosis, as coming in kind of two flavors. One is rapid, progressive, systemic disease, the skin, the lungs, the blood vessels, the kidneys, all may be affected fairly early on. And the second flavor is sort of slowly limited progression scleroderma. And the centromere antibody helps divide that up. So when you have a centromere antibody, it means you're going to have limited cutaneous sclerosis. And so that's really what the point of the question is the sort of prognostic indication that centromere antibody gives you. And I would commend, the answer to reading through this. Scleroderma is a dreadful illness that we have not a clue on how to really treat it. And it's for rheumatologists, it's very frustrating. And so if you don't feel like you got your arms around scleroderma, I don't blame you.
So other than the antibody test, is there anything else in her clinical presentation that can tell you limited versus diffuse?
Well, she doesn't say that her skin fingers are all hidebound, but it says difficult to tint. So she may have some early, and she does not have nail pitting, digital pitting. She's not lost fingers from severe ischemia or hasn't gotten pitting from severe ischemia. And she's got some small telangiectasias. It doesn't say anything about her face, but presumably she doesn't have a tight face. And, she's got no difficulty swallowing, dismount exertion, or hand stiffness. All of these things say it's relatively mild, but she's young, and this has only been going on for 9 months. So you still follow her very carefully and keep an eye on just how she progresses. We have no medicine that really prevents this. We give her vasodilators, calcium channel blockers for her Raynaud's, and we probably give her a PPI for her reflex.
Mm-hmm. And is it pretty, does limited ever then transition into diffuse, where you see
Yes.
people with the
Over time.
anti-centromere and then
Over time,
got
it can absolutely, in 10 years, it may catch up with somebody who presents with far more skin involvement. And you pay attention to the lungs, and we're going to get to this used to be called CREST, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. They've gotten away from saying that as much, but we call it just limited.
Okay.
All right, so here's another great question. He's got diffuse cutaneous systemic sclerosis, and he's got some lung disease. His CT shows ground glass changes. What's the most appropriate treatment? And this is going to be mycophenolate. But stay tuned. At some point, nintedanib may be the right answer. It's new and it hasn't been studied as much. We used to give cyclophosphamide for this. So we got, both of these answers I think would be acceptable, but what they want you to use is mycophenolate. And mycophenolate, just parenthetically, for interstitial lung disease with an autoimmune background, whether it's scleroderma or Sjogren's or rheumatoid, or with just a positive ANA or rheumatoid factor, no real underlying disease. That type of interstitial lung disease tends to respond reasonably well to mycophenolate. So that's maybe that's vitamin M for us. And so this is kind of a nice little discussion in your answers. We try not to use cyclophosphamide in these chronic diseases because it just you can't use cyclophosphamide for long periods of time without getting into really bad toxicity.
diarrhea and weight loss, again, diffuse cutaneous.
Yeah, so this is kind of a interesting question. The bowel disease in scleroderma is hard to treat. What they're asking for is ciprofloxacin for the bacterial overgrowth syndrome is what this sounds like. So loperamide might help for the diarrhea, but the ciprofloxacin is for the overgrowth syndrome. All right, we're into the home stretch. Here's a young woman with this rash with these annular lesions and positive ANA SSA antibody. And so this is a little bit unusual, but we all rheumatologists should know this, and maybe you now will too. This is subacute cutaneous lupus, and looks like, well, only a few got this. So subacute cutaneous lupus is this peculiar rash syndrome associated with the SSA antibody, and you know, not very much else. And so that will be. So discoid lupus, where most of you took, it is scarring, often in the scalp. The hair comes out. These changes on her skin are relatively superficial, and that's not for discoid lupus.
And these lupus syndromes are fairly discrete from each other. They don't coexist or overlap or develop one to the other.
Yeah, sometimes this is in the context of lupus, but of systemic lupus. Sometimes they're drug induced, and you know, it's different than discoid lupus, and it may or may not progress to, you know, bad systemic lupus. So it's a reasonably common skin disease in lupus. And it's the SSA positivity that probably is the key giveaway here. Okay,
Sjogren's or their husbands.
This lady has Sjogren's for sure, but now she's sick. And so what's the answer here? She's got low complements. She's got positive rheumatoid factor. This is lymphoma, because that is a risk in sort of active Sjogren's syndrome. And so that most of you got that. And Sjogren's is pretty common, but the things that you worry about are when they have low complements. C4 here is particularly low, and high titer SSA antibodies. She's got some protein. We might do cryoglobulins, and it does show immunofixation, shows a monoclonal IgM gammopathy. So that she likely has cryoglobulins as well. And that's a risk factor for developing lymphoma. We don't know exactly what to do about this, but we follow them more carefully and just realize they have a markedly increased risk of lymphoma when they have these things. So you kind of surveil.
And you just kind of, is there any way you can screen earlier for them, or you're just waiting for kind of some B symptoms or from lymphadenopathy or?
Yeah. Yes. I don't know. In other words,
okay.
It's been known for years that they have an increased risk of lymphoma, but exactly what to do about that is not clear yet. And there are no studies that I'm aware of that say, okay, here's what you can do to head this off. I think they would be treated with hydroxychloroquine, but we don't put them on other immunosuppressives or tumor, you know, we don't give Rituxan, for example, until they develop this, so that we would be talking with our oncology friends.
Got it. Oh, jeez. Shoot. Okay.
All right, we're almost done here. This is a good one too. The key here is 30 years of sort of poorly controlled ankylosing spondylitis, and now he's got edema. And this is amyloidosis. It's the amyloidosis that comes from elevated serum amyloid A protein, which is an acute phase inflammatory marker. And we used to see this with other chronic diseases. Yeah, so D, everybody got this. Good for you. There's two, we used to call it primary and secondary amyloidosis. The primary is light chain, and the secondary is this serum amyloid A post-inflammatory, chronic inflammatory. You can get it with tuberculosis, endocarditis, rheumatoid arthritis in the past. And this guy hasn't gotten any medicine. And we use TNF inhibitors nowadays with good results in ankylosing spondylitis. But, he was born too soon. All right. Is this the last one? I think so.
It is, yeah.
Hey, you guys have been, well, you talked my ear off. I don't know. You've been asking so many questions. I'm worn out, but I'm just kidding. You've answered the questions well. So, this is a question with probable lupus. What's the next test? And the answer has to be just an antibody, anti-nuclear antibody. Because if it's positive, a lot of times the lab will go ahead and run the panel and you'll get far more information. And so you can't have lupus without a positive ANA, and that's where you start. And you can have lupus with none of the others because they're not nearly as sensitive. They're specific. So Smith and double-stranded DNA antibodies are quite specific for lupus, but they're not sensitive. And so the ANA is basically 100% sensitive for lupus. And so that's where you start. But you should also know that ANAs are very common, and you should be cautious in making a diagnosis of lupus because it's a chronic disease and people, this is an important diagnosis. And so there are criteria for lupus diagnosis, which includes, clinical as well as laboratory features. And the panel of antibodies that happens after a positive ANA helps you get down that road. Any questions about ANA? Does that make sense? In other words, just what percentage of lupus patients have a positive ANA? The answer is 100%. What percentage of patients with a positive ANA have lupus is a very different question, and that's much lower, right? Well, you're all going to pass the boards. You've done very well.
Right? I was impressed, man. But yeah, I mean, you guys should take advantage. Dr. Starkeybaum's still here. You don't have anything else after this. So if you have any questions, they're all experts.
Or a patient you've seen, somewhere along that illustrates some of this stuff.
Yeah, I find that we have a patient right now at the VA who we're all convinced has some sort of rheumatologic disease, keeps having recurrent pericardial effusions and pleural effusions and very high ESR and CRP. But all of the antibody tests have been negative. So it's like a very frustrating, unsatisfying situation.
Yeah.
And as soon as her steroid dose comes down, everything comes right back up. So it's like she's going to be stuck on high dose steroids. I don't know.
Yeah, and steroids are bad for your health long term. And so in these situations is it an auto-inflammatory as opposed to an autoimmune disorder? And most auto-inflammatory diseases, are the genetic ones that kids get, but we're seeing new onset auto-inflammatory type syndromes more and more. Adult stills comes to mind as one of them. And of course, this new syndrome called VEXAS. How many of you guys have heard of VEXAS? VEXAS. So it's a autoinflammatory syndrome with skin rash and often relapsing polychondritis, but multi-system disease. And it's due to a somatic mutation in an X-linked DNA called ubiquitin. And it, it's an esoteric kind of thing, but it can be confused with lupus, relapsing polychondritis, adult stills, all kinds of things. And they've seen a couple of cases out of the VA. So in this case, while you're pursuing maybe a genetic diagnosis, you could consider adding Anakinra, which works quickly, and then you get the answer right away. And just to see if that will help spare the steroids, you could use methotrexate if his kidneys aren't affected. You could just, whatever it is, that steroid is going to wear out his welcome, and you need to get him down, and regardless of what the serology show. These are tough questions, even for rheumatology. The gout questions you guys should be able to handle. Gout is a very common and often undertreated disease. Nowadays, you don't need crystals to make the diagnosis. Somebody who has podagra, for example, and has a uric acid that's 8, that's a clinical diagnosis of gout. And we tend to, the treatment of acute arthritis and gout is different than uric acid lowering therapy in gout. And so, you can use a short-acting NSAID, ibuprofen or indomethacin or steroids, or even colchicine for the acute gout. If it's polyarticular in the hospital real sick, then we use vitamin A that we talked about. But if they have kidney disease, or they have tophi, or they have multiple recurring attacks, then they should be started on allopurinol after the HLA-B5801 antibody test. And if they have kidney disease, when you start allopurinol, we nibble up on the dose. We don't start 300. We start at either 100 or even 50 milligrams a day, and slowly go up, watching for the rash or for a flare of gout, and anticipate that. Patient will tell you, well, I'm allergic, doc, because I get a gout attack when I start my allopurinol. Well, that's not an allergy. That's part price of doing business with allopurinol. But and we continue to increase the allopurinol until the uric acid is 6 or less. And if you don't get enough allopurinol and you don't get to 6, you're not solving the problem. It's a chemical problem. It's just the uric acid concentration will go down, and the uric acid crystals will go away.
Thank you so much. That was all very educational. I hope everybody learned something, even though there were so many people that got the right answers.
Yeah.
I'm very impressed.
You guys did good. Well, that's